go after the infarct-related artery. So CP goes in, and now the question is that, what's the next thing, Do you revascularize everything? Do you just treat the culprit vessel? So we identified with the OCT. That didn't play well. There was a ruptured plaque as the ostium of the circ, somewhat of a sluggish flow in that territory. So again, we went ahead and we unloaded the LV first, and then we did the PCI, the infarct-related artery. And that's where we learned from the culprit shock, just treat the culprit lesion in a state of shock. Now, this complete versus culprit-only PCI is somewhat debatable, and there are two schools of thought. If you look at the literature, some would argue that complete has better outcomes versus culprit only. And again, there are two schools of groups. I don't know if we have a final word on that. So for this case, I think we went ahead and we just treated the culprit lesion. And now the fun begins. So he goes up to the ICU, and now we are finding that there is a discrepancy in his pulses. So Imran talked about his hesitancy of implanting the device earlier in the day with vascular complications, and that's the real problem, right? Patient is in shock on multiple pressors. You put a 14 French sheath, and you occlude, and you decrease the diameter of that vessel. And on top of that, I think the second issue, which I don't know how many of you have experienced, is this Foley, where you see frank hematuria. And that is also a big issue. So what do we do about that? So this is around 7:15 in the morning. This is roughly an hour and a half after he comes out from the cath lab. So on the bedside, the surgeon, the heart failure doctor, myself, we made a decision, this CP needs to come out, but he definitely needs support. His EF is compromised. He's just had an acute insult. So a patient makes it to the OR in the next hour, and he gets an axillary 5-5, and comes out from the OR, and around 10 or 11, you can see the Foley at the bottom. He's pouring tons of urine. So his initial creatinine at 4 in the morning was 1.5, and the next set of labs, which is around noon, his creatinine has peaked to 4.5. So the good thing is that his initial lactate, which was 6.7 on initial presentation after the 5.5, it's down to 1.8. So in terms of the clinical course of this particular case, after 5.5 escalation from CP, we were able to successfully wean down pressors down to 1 from 3 pressors. He did actually get extubated the very next day. So post-arrest day 1, he was extubated. On the 20th, he had an echocardiogram, which I will show you on the next slide. On the 21st, he had issues with the lung, developed an aspiration pneumonia, got reintubated, subsequently required 2 more days and was extubated on the 24th. On the 25th of April, he had the axillary impeller removed. And on the 26th, he was already on COREG IMDOR. ACE were held because his creatinine was still high. So this is a day 4 echo. So as far as his post-hospital course, he is now 3 months out from his event. I just saw him in the office earlier in the week. No ischemic symptoms, no heart failure symptoms. He has completed his cardiac rehab. And actually, this weekend, he's planning a trip to go to Pennsylvania on his camping ground. He's on all 4 classes of GDMT and doing really well. So what does this case highlight? I think it's important to understand that in our experience at Hackensack, I think we feel that unloading definitely helps to reverse the hemodynamic shock. I think we need to appreciate the difference between a hemodynamic and hemometabolic shock because you can reverse the mechanics of physics, but you cannot reverse the chemical architecture disturbance. So once your mitochondria are disturbed and you have an inflammatory milieu, that is not something you can mechanically reverse. So that is important. So phenotyping is important. Phenotyping needs multiple groups of clinicians. I think interventionists may not be the smartest. I think heart failure doctors are much smarter at phenotyping, making use of numbers. I don't hate to admit that, but again, having said that, I think surgeons, heart failure, interventionists, critical care, intensivists, I think this is something which is extremely important to. Lesson 2, this is the danger shock, right? It showed there is mortality benefit, but look at the number of patients who ended up on dialysis and the number of patients who had limb ischemia. So if you look at the details, even though there was benefit in spite of having this high number of patients ending up on dialysis. Now, keep in mind the case that I present would have never been included in the danger shock, right? It's a circ ruptured plaque, multivessel disease. His GCS is less than 8, so he was excluded from the danger shock, and he had an amazing recovery. Why do we say that? Because this is our experience from Hackensack. This was our data we presented at the ACC earlier in the year. So if you see this, it may not be very evident to you guys. On the left is the slide that depicts our own vascular complications in Hackensack in the year 2019. So we had complications as high as 26%. And as of last year, we have brought the complications down to roughly around 3.9 to 4%. Now again, this did not happen over a year. This took us about 6 or 7 years of commitment, hard work, multidisciplinary approach, having all specialties being involved. So again, it was like a team game. Now those bar graphs that you see actually are reflecting our mortality. And the first set of bar graphs is our survival. If you look at those year after year, even though the device was being used for all those years, but mortality changed over a span of 7 years. And why is that so? Because I feel that if you have compromised renal function, that would impair your ability to reverse the metabolic components of shock. If you have ischemic limb, you will not have the mortality benefit. And if you see in our graphs here, we were successful in improving our shock survival, AMI shock survival to upward of 72%, similar to some of the Detroit and the Innova experience. Again, it takes a whole team approach. You know, this happened over 7 years. There were multiple specialties, multiple teams involved, weekly, monthly meetings, reviewing cases, having open discussions about what went wrong, how can the systems improve, what is the ancillary support services, how do we recognize things, how do we recognize limb ischemia. So again, not an easy process. So again, I think fixing an infarct-related artery in AMI is important, and so is reversing the hemodynamic component of shock. But equally important is to pay attention to all the details that revolves around this. So in conclusion, AMI shock is a team sport, and any team sport needs a robust team. Quarterback cannot give you the finals. You know, you need a good runner back, you need a defense line, you need an offense line. Mortality benefit, danger shock has already established that with hemodynamic support, in spite of having a very high complication rates. Unloading in the setting of AMI first before infarct-related PCI may be the right approach. I think we need further studies. I know that Recover 4 is no longer going to be going through because of concerns with the benefit with danger shock. But what we don't know is that danger shock was only partial support. I have been using Impella CP for over 10 years, and I have had amazing experience with using Impella 5.5 with multi-vessel PCIs with EFs of 10%. It's a totally different experience. So having a complete support versus partial support, I think, is important to understand. And I think the future for Recover 4 may be that we should look into complete versus culprit versus partial versus complete hemodynamic support, because I think this is something which there are gaps in the AMI shock space. As far as the elephant in the room, there are real issues with CP. We all face that. We all see that in our clinical practice. Limb ischemia is real. We have seen disasters happen that. But having said that, if you have vascular surgery, a proactive team, an ongoing program, you know, you can really bring your complications down to single digits. So we were successful in doing that. And I think you guys can do that. Thank you.
Awesome case. I have a question for you. So LVEDP of 22 does not strike me as super duper high that requires significant support. If there was no hemolysis, would you have changed the support that you're giving that patient specifically?
Yeah, that's a good question. So I think that's what happened at the bedside, is that he did not, hemodynamically, the CP was adequate enough to reverse the hemodynamic component of it. The issue is that it was compromising. So we have these lymph flows where we attach these pulse oxes on the feet, Edwards, which tells us what the hemospheres are. And the right leg was around in the 30 range, and the left was like 70. So the leg was ischemic, for sure, with the CP. And he was having hematuria, and was having a renal hit. So to answer your question, in danger shock, you had almost like 30–40% patients who were ending up on dialysis, right? So what is the price of that in the contextual reference of AMI shock? So in this particular case, he never ended up on dialysis. His creatinine went up to 5. He went into post-ATN phase. And our experience at Hackensack, we feel that 5.5 have enough adequate perfusion to the kidneys, and we have seen a lot of these patients avoid dialysis in these settings. So yeah, you're absolutely right. From the hemodynamic component, partial support may be adequate in a substrate of patients. Having said that, this patient is not on dialysis, never needed dialysis, and again, the limb ischemia was never an issue for him. So I think those were the two components that played in decision-making for the escalation.
I'm going to ask the panel here, do you think the device helped him, or do you think just revascularization, if you've left him alone with that LVEDP, he would have recovered by himself?
Thank you. First, I'd like to congratulate you on phenomenal work. I think everything you've done, was definitely the reason why this man is alive. To answer your question, it emphasizes few things, I think. In patients that come in like this, who's really cardiac arrest, have LV predominant shock, and I did see that you had a swan. I'm sure this probably happened before the impella, and that probably helps you stratify, At that point, you have a patient on the table, has an ischemic culprit, you define the anatomy, but they're still on multiple shock. You just have to decide which way to go. And in your case, you either had to salvage with an impella or ECMO, or maybe Acpella. We all could agree, I think, in this situation, balloon pump's not going to offer you much benefit. And I do agree that the impella CP, because of the hemolysis and the bleeding, you need blood at the end of the day. Even if you're pumping, if you're not pumping blood, you're not perfusing the body. The fact that you're having hemolysis, and as they did in Danger, which actually they ran at maximum allowed P level for 2 days after they implanted, when I was reviewing their protocol, which is not what we typically do. We don't keep patients at P8, P9 for 2 days after AMI shock. The problem is what you just said. It's just not enough. It causes hemolysis and it doesn't perfuse enough. But I think the impella CP in this situation is a very important salvage. There's no way that you can put him on a 5.5. ECMO is a good option, but at a much higher risk of complication and a lot more resource utilization. So I think it seems like here you define the hemodynamics. You decide to go as a CP. You salvage it, even for a few hours, and then supported them adequately as a 5.5, which I think is really the best device we have for LV predominant shock. Good job.
I think congratulations, it's a great case, Haroon. The only other thing I would add is that I practice in Illinois. We've talked about this before. Offline, I mean, there's 82 cath labs in the state of Illinois, hospitals with cath labs. That's absurd. So if, the device is great, the device helps, but then you have to respond to complications and issues in real time. So if this person gets an impella, Impella, there's 2,500 cath labs in this country. Impella is in at least 1,300, maybe 1,400 labs. If you're out in the sticks somewhere with an Impella and a cold leg, and the inability to sort of rapidly transition to 5.5, I think that's going to do you in.
Sandeep, that's a great point. So I was actually with Bill O'Neill a few months ago, and he actually wants me to publish our CP to 5.5 outcomes, which are pretty impressive. And exactly this is the question that came to mind, is that there are 82 labs, a core leg in 100 miles from your hospital. But remember that there are vascular surgeons in every hospital. And like I say, shock is a team sport. They should be part, and we should. I think my thought process is that this is a team sport, and for some reason we feel that we are the only players in the game. Every hospital system has a vascular surgery program, and they are very, very competent in dealing with that, right? Do you agree or not? And I think the challenge is that we have isolated our mindsets into acting in silos. So I think we need to create these networks, or at least I spoke with Bill, and my proposal was that let's create networks for shock that involves all specialties, and let's be a real team player. Imran discussed the case, and I think Rajan made a comment that it should not be an operator experience dependent, right? If you have a weak quarterback, there are 9 other players in the team, 10 other players. You have runner back, you have defense line, you have fence line. So I think personally, you make a great point. In real world, we have these sparsed out labs with data and enough support system. The question is, why are we playing in silos? We should play the sport as a team.
It's great comment to end on, Haroon. Thanks very much for that introductory lecture. It was terrific. So we're going to move on to our next speaker. So next up is Karthik Ranganathan. And Karthik is going to present a case of anterior MI and cardiogenic shock. And Karthik, if you can keep it around 10 minutes for the presentations, we'll get a couple of questions in before we move on. Thank you.
Thanks, Dr. Kapur, for the invite. So my case is going to be an anterior MI. So the reason we're presenting this case is like how we would have done differently. So this was done like 2-3 years back. 49-year-old male, no significant past medical history, had chest pain while he was in shower, was brought to the emergency room, anterior ST elevation on the EKG. And the point is, like the first troponin was negative, so it wasn't a late presentation. He came as early as possible. Initial blood pressure was 80/60. He was cold and clammy on exam, 12 liters of high flow nasal cannula, and he was taken directly to the lab for catheterization. As you could see here, this patient's LV EDP was 33. His LV systolic pressure was 75. And this first picture, look at the femoral angiogram. When most of our fellows, they ignore this picture and go to the next one. But this picture actually tells you not just the axis vasculature, but also what is the patient's cardiac output is. He's in a really slow output state. And here you could see the culprit, proximal LAD stenosis. So the lesson 1 is MCS before PCI, as previously discussed. So femoral axis, make sure the vasculature is adequate, and you just need to obtain an LVEDP. A high LVEDP, lower systolic pressure, and a poor flow in the femoral angiogram actually tells you this patient is in cardiogenic shock. You don't need a right heart catheterization before you proceed for MCS or PCI. And in this patient, we should have supported this patient with Impella CP as per Danger or NCSI. But at that time, this patient actually did a PCI first, so we managed to keep the blood pressure up with vasopressors. So in this situation, vasopressors, keeping the blood pressure up is not equal to perfusion. So patient was still getting hyperperfused while we were fixing the LAD, and an intra-aortic balloon pump was placed post-PCI. And a right heart cath was done. There is no right atrial pressure documented, but you have to take my word, it was less than 14. Patient was supported with the cardiac index of 1.8, and on levo-fed and balloon pump, this patient was transferred to the unit. So lesson 2 with escalation of MCS. So either you do a balloon pump or Impella-assisted PCI. After we achieve TIMI-3 flow, the next step is to do a right heart cath before the patient leaves the lab to see if the patient is adequately supported or not. If the patient is adequately supported, if your cardiac index is more than 2.2, then you go to the ICU. If you're still under-supported, then we have to phenotype. Is it because LV predominant shock, or if it's a biventricular shock? If it's an LV predominant shock, we make the decision to go for more LV support at that time. But our patient, we clearly could tell the cardiac index was less than 1.8, and after he went to the floor, he had like poor urine output, and the creatinine was going up. On the echocardiogram, the right ventricle was normal, so we decided to go for Impella 5.5, but this decision was made 24 hours later. By this time, I think his troponin was more than 10,000. And lesson 3, in VT storm, let's say if the patient has biventricular failure, once you identify bioventricular shock, there are multiple devices that we can use to upgrade. At our institution, we definitely go for VA-ECMO. We keep the Impella CP or the balloon pump in until we figure out the exit strategy in these patients. So limitations to this approach is not all patients we can use the same approach. Patients' age is important because in most of the studies, this was tested in patients who are less than 75 years of age. But when you get an 80-year-old or 90-year-old, we are not going for an ECMO or sometimes not even an Impella CP because of the peripheral arterial disease. And when clearly there is no exit strategy, then there is a recovery of native function is less likely to happen, then we don't keep on putting more and more devices. And not to forget about the complications. So our patient, he did not have recovery of heart function. So he was listed for heart transplant on day 10. On day 16, his Impella got thrombosed. He had a pump thrombosis. So he had to be escalated for VA-ECMO and got transplant in 48 hours. So we have to be mindful of the vascular device and the complications that comes with it. And we put the devices in the lab, but we need to have a whole team taking care of these devices in the unit. And why is this? Why are we discussing about anterior MI? Why I wasn't given inferior MI or a lateral MI? Because in left main and LAD shock is totally different beast compared to the others. Because patient can present initially with normotensive, like normal blood pressure, tachycardia. If you just say the blood pressure is normal and the patient is not in shock, I think we are being fooled here. Because they have a high sympathetic response or surge due to myocardial ischemia. I think these patients, despite a normal pressure, if they're cold and clammy on exam, they're still hypoperfused and they're hypoxic, they're typically in pulmonary edema. And whenever you give sedation to the lab or if you decide to intubate, you have to wait to put these patients on ECMO because they're going to collapse right in front of our eyes. So the take-home message is, step one, pre-PCI MCS, preferably a femoral axis so we can get an idea of the vasculature, and the angiogram tells us what the cardiac output is, and the LVDP tells us that the patient is in LV shock or not. Then the post-PCI right heart cath is important to phenotype if the patient is adequately supported or not. If it's inadequately supported, is it a LV or a bi-V failure? And then we can plan the escalation based on that. And there is an AHA circulation document which talks about the escalation and de-escalation strategy. And there is a flowchart or algorithm, if you focus on the middle, where it talks about patients with cardiogenic shock, how we can go step-by-step escalation. Thank you.
So while we're at this slide, I encourage everyone to look at it because there are maybe over 20 considers in this statement. So there's a lot of missing data that we need. And despite me agreeing with you, there's really no robust data to say pre-PCI support is going to have an impact on mortality. Yes, we practice that, we preach that, but the reality is the guidelines are not reflective of that. And that's one of the challenges. I have one question about the case. Was he recathed again with the VT to see why he's had VT 3 days after?
No, that was more for escalation. This patient didn't have VT.
Okay.
But part of the escalation protocol, if somebody has VT storm, even if it's an LV failure, we still go for a biventricular support upfront. And to your point, whether MCS pre or post, so we used to put patients on balloon pump, send them up to the unit. And 4 hours later, we get a call saying the patient is poorly supported. Then the patient comes for an Impella, goes to the unit. And then 24 hours later, we put an ECMO. But by this time, the end organ dysfunction has already started. And even if you say, okay, we evaluate for transplant or VAD, but now they're in multi-organ failure, they're not a candidate for anything. And especially left main, either we start with the balloon pump or not. I think most of these patients, at least in our center, they end up leaving the cath lab with a CP and an ECMO. It just depends on like how we want to. Do you want to straight away revascularize and then do VT, VFib, CPR? Or should we do upfront at least one device, take care of the culprit vessel, and then do the right heart cath and support them?
Yeah, I mean, this field is obviously riddled with consider this, consider that. So let's do some mid-session yoga. So I'm going to ask you all to raise your hands as high as you can. So how many centers here are using intra-aortic balloon pump for acute MI cardiogenic shock? As high as you can. Okay, good. How many centers here have abandoned balloon pump and are focused on Impella and ECMO for their AMI shock algorithm. Okay, so a pretty good mix. And then how many centers here have VA-ECMO on site? Okay, so a fair number of ECMO. And out of those centers that have ECMO, how many of them are driven by interventionalists cannulating as opposed to surgeons? Okay, so much fewer. Okay, so basically the illustration from the hands up in the audience is that the balloon pump Impella question is still very much alive in the United States. In Europe, there would be no hands up for balloon pump, and in fact, it's almost sacrilege to say that four-letter word. The other challenge is that a lot of centers don't have access to ECMO in the cath lab. And so that makes it very challenging for escalation strategies, because now you're handcuffed basically to balloon pump or Impella. And then if you have to escalate, you're really either doing multipressor escalation or you're transferring. So basically the hands up exercise illustrates the challenge of Recover 4. So Recover 4 in concept is a great trial to be done in the United States of America, where we have never done a randomized controlled trial in cardiogenic shock. Okay, it's never been done except since the shock trial. The second point is that in Recover 4, if you're randomized to the non-Impella arm, now you can use everything but no Impella. And so for all the groups that use Impella first, that's not a viable path. Half of those people would say we're not doing that. The second thing is that if you're in that group and you have a balloon pump failing, you have to escalate to VA-ECMO. And so now those same centers don't have access to VA-ECMO, or it's surgically driven, or they're transferring out. So just to give you some insight as the principal investigator of the now defunct R4 trial, that was one of the challenges we had, polling centers across the United States, saying, would you participate in R4? And in concept, a lot of people really love the idea of an RCT, but in practical execution, very difficult because of the diverse access to resources and the bias that's still quite spread, in the U.S. So, I'd love to hear from the panel about thoughts on Recover 4. Should it be resurrected? Should it be done in a different way? If you had to redesign it, what would be your top choice? So we'll ask Sandeep, and then we'll move on to the next talk.
Yeah, I mean, I think it answers, potentially answers a very important question that's still out there. I think the enthusiasts will look at danger and say, see, I told you so, but it's sort of danger kind of, 10 years to run a trial means that there is significant secular trend in that trial, in the way you're actually doing these cases, whether it's vascular access or managing complications or any of that. That's point number one. Point number two is that it sort of sweeps under the rug all of the vascular complications and bleeding and hemolysis and renal failure and the associated mortality, in-hospital mortality. If you look at the contrast-induced nephropathy literature, there's a multiplicative effect on in-hospital mortality if you have contrast nephropathy. Whether you choose to believe it or not is a different thing, but so there's definitely some disparities, and there's an exponentially higher number of disparities in the shock world. So I think the trial needs to be done, but practice is practice, and we saw this in in PROTECT also, right? I mean, the minute you were randomized to Impella, all of a sudden you're beating your chest and atherectomizing everything, and if you were randomized to balloon pump, well, that left main's not as bad as I thought it was. Let's just fix the circ, So I think that's the practical challenge.
Thank you. Yeah, I fully agree. Navin, we've had this conversation. Recover 4 was a great design, but it's not how at least we've learned how to treat those patients in terms of there's one arm where, all Abumed product, and then all arm non-Abumed product. And then in reality, that's not how we treat our patients, because we've learned from all your work and the Detroit work, where we, do hemodynamic assessments and decide how to go. And for us, at least, it was very difficult to justify going from a patient who was a non-responder to balloon pump to go to ECMO before, even if they have an LV predominant shock, or if they, if they have BIV, maybe there's a, case to be made to go ECMO, but we didn't have that luxury, and that lack of ability to cross over was really the biggest because we didn't want to put our patients at risk, even though at the time, when we talked, it's like, well, there's no benefit to, there's no proven, there's no randomized trial showing that Impella is the way to go, so why do you find it that hard to do? But now with danger, that's really, understandable how the recover for, stopped. Another comment I would like to make is about, if you look at danger and shock trial, the mortality rate of ACS, even both group, is still high, and even in danger, it's still higher than the IAB shock. Now, obviously, the patient were different, but it's still a very problematic, if it's a serious lethal problem that we're dealing with, and to restrict yourself in your tools that you have when there's no data, strong data on either side is also difficult. Now, I'd like to ask you, sometimes I use a strategy, and I know that a lot of people, I have not given up on IABP, and primarily because I have really seen patients in clinical practice that are really responder, those that have high MAP, high SVR, lack of RV failure. You put in a balloon pump and you check the cardiac output pre and post. Even 10 minutes, 15 minutes later, sometimes you see the heart rate drop. There's significant improvement. So, is there a role for this approach where you put I think the balloon pump $750 or is very cheap device. You just put it in, see if there's a response, keep them on the table, and assess that before you give up and send them up on a balloon pump. Just assess that that group that are IABP responder, especially knowing the risks of that comes with an Impella from bleeding and hemolysis.
Yeah, so I think you pretty much nailed it right there with some of the comments you made. I mean, the idea of doing stepwise escalation from balloon pump to next therapy, picking out that SVR that's elevated. I mean, that hemodynamic characterization is so critical. So, if there were a trial to be designed, can you do a hemodynamic assessment, then make decisions? The luxury of that is also not a reality in private practice, where all the STEMIs are. The STEMIs are in the community hospitals. In the academic medical centers, we can sit there, and I've forced all the fellows that are in this room to basically look at hemodynamics, do all sorts of things that take a lot of time in the cath lab. And now those fellows are out in clinical practice, and they pretty much will never do any of the things that we did because it's just not feasible, and it's a different mindset. So I think before we redesign or propose redesigns, we have to really think about, how that trial is going to fit into a clinical practice environment where STEMI shock lives, which is not in the academic medical center with every device, at your disposal. So there's a lot to discuss there, and we'll continue the discussion as the session goes on.
I just have one comment, coming from someone who just finished fellowship a year ago, from like what I was doing in Impella, from sort of the psychological standpoint, I've been in situations where patients coming with the acute MI shock, EDP maybe in the mid-20s, systolic in the 80s, reduced index, this is before I start dropping wires down the coronaries, start inflating balloons, and before the reperfusion injury sets in. So having Impella in place sort of helps me from the psychological standpoint, knowing that the patient is supported. I can take my time, do IVUS, OCT, figure out the corporate lesion, do revascularization the right way instead of, my hands are not shaking anymore. So evidence, it might not be evidence-based, but, it definitely helps me dealing with the really sick patients. And, fortunately, I trained at a place where I became really comfortable with an Impella device. So to get back to sort of your comment, Marwan, the EDP in the 20s, I've been in situations like that where the cath lab staff like, are you sure, doctor? The EDP is like 20, 23. Why are you putting Impella? It's like just so we can do the case the correct way.
Awesome. Thank you. Great case. Moving on to the next speaker, Dr. Kapur.
Great. All right. Thanks. And Mike, I don't remember your hands shaking ever during fellowship. So that's right. So all right. So we're going to talk about ECMO-assisted CPR for STEMI cardiac arrest. So a lot of centers here have ECMO. A fair number of centers do not have ECMO access. But this is becoming a really front and center issue, I think, for interventional cardiologists. And it's mostly driven by this. This is the AHA recommendation that came out in December. It is now a 2A recommendation for extracorporeal CPR. So when you look at the guideline, use of eCPR for patients with cardiac arrest, refractory to standard ACLS is reasonable. when provided with an appropriately trained and equipped system of care. So with this, and the two trials that supported this are shown here, one from the Czech Republic and the other from Minnesota, the ARREST trial. So this really changes the game quite a bit in terms of eCPR, access to ECMO, where a lot of cath labs now are managing cardiac arrest. Paired with the publication of the updated guideline was this scientific statement from Janice Thomas-Holland, who's here at this meeting, if you get a chance to talk to her. And what they essentially did was talk about the algorithm of care. And this is really in cath labs, out-of-hospital cardiac arrest. One of the things that I'll point out to you here is this part right here. This is a really critical box to read carefully because this is the inclusion-exclusion criteria for upfront evaluation of whether or not a candidate should be considered for transfer to an eCPR-capable center. And then from there, there's another set of criteria, hemodynamic and metabolic criteria. But notice the lactate threshold is 18, as you heard from Jason this morning, and they're looking at end-tidal CO2s and arterial PaO2s as a cutoff. So take a look at this document. It's critically important to understand how you're going to manage out-of-hospital cardiac arrest in the cath lab. And then paired with it was an interesting statement about the idea of mechanical support before VA-ECMO in patients, and then considering single-access LV assist for PCI, and then looking again at that algorithm as well. So again, a lot of considers, but now that it's a 2A recommendation, I think these guidelines are now going to become something we're implementing in clinical practice. So I'll illustrate, unfortunately the videos got changed here. This is a patient who came in, 60-year-old with an inferior STEMI. I got activated driving in from home, patient's awake, talking in the emergency room. Fairly straightforward inferior STEMI, but while awaiting PCI for the cath team to come in, the patient goes into cardiac arrest. So now we're doing CPR in the emergency room, and the patient's not coming out of cardiac arrest. They're having refractory arrest, and we go ahead and cannulate in the ER with a 23 French venous cannula and a 15 French arterial cannula. Patient comes up to the cath lab, and unfortunately the second video shows a ventriculogram that shows a horribly impaired ventricle, despite this being an inferior STEMI. We went ahead and repaired the RCA, which took about 15 minutes or so. But what's important to note here is when we look at the aortogram, what you're seeing here is basically very slow, sluggish flow around the aortic arch. And this is something that if you start to operate and you do these cases, I would recommend taking a quick look at the aortogram and doing a look to see where is the mixing cloud. The problem with this mixing cloud position is it's sitting right around the great vessels. So in these types of cases, what you're going to see is cardiopulmonary injury from cardiac arrest. They're hypoxemic, they get put on VA-ECMO, and they have poor cerebral oxygenation. This patient also had very difficult access for PCI. There's no real Impella option in this case because of poor access. And then also using VA-ECMO with an Impella is a challenging thing to do, and I'll illustrate why in a moment. And this patient, as you heard earlier from Jason this morning, classically had LV recovery, but brain death. And this is a 60-year-old who was in hospital cardiac arrest. So there's a very short downtime. This is bystander CPR by highly trained physicians. This is a really important paper to look at. This was written in part by Robert LaRusso, who's the head of research at ELSO. Came out in 2022. And what this talks about is this concept, and the way I read this was looking at this idea of cardiac recovery and brain injury. So a patient comes in with severe LV impairment. This is a patient you might go ahead and put on an Impella. But in the second column, you're looking at a patient who has severe LV and lung injury. That's your out-of-hospital cardiac arrest patient. The CPR, the bilateral pulmonary edema, the aspiration during the arrest, all of that leads to lung injury in the presence of cardiac injury. Now, what happens is, over time, you may start to get LV recovery, but have persistent lung injury. And what happens in that case now is you're ejecting more and more deoxygenated blood towards the brain. And so what you'll notice in this diagram is the yellow dot. Where is this perfusion system? So once you're on VA-ECMO with severe LV impairment, aortic valve not opening, the VA-ECMO system should perfuse the arch, theoretically. But as you start to get native recovery, the little yellow ball mixing cloud starts to move north. And as you start to have LV full recovery, now you see the mixing ball is down here. And you're sending all that deoxygenated blood up to the brain. And so this is where you get normal LV, severe lung injury. You're in a very difficult spot. So this is what leads to cardiac recovery and brain injury. So with cardiac arrest, especially in STEMI, we're taking care of half the problem by unloading, but then we've got to think about how are we going to manage when the LV recovers, and we still don't have lung recovery. Now, this is a really nice set of papers from Japan illustrating some of the concepts of combining VA-ECMO with Impella. So again, in the setting of lung injury, when you put an Impella in, now you've got, even though the ventricle may be fully impaired, you're now driving more of that deoxygenated blood through the arch. And this can then lead to, again, worsening of that neurologic hypoxemia because now you've combined the two. And so really the treatment option in this case is to do VAV-ECPella. So for all the operators in the room, that's about 81 French worth of holes. So bifemoral, IJ, as well as the Impella placement and your DPCs for distal perfusion. So now you're starting to really escalate and accumulate vascular injury risk, bleeding risk, trauma, et cetera. So I'll illustrate this in a case that I took care of just day before yesterday. This is actually a very unfortunate case of a 60-year-old gentleman who also came in with out-of-hospital cardiac arrest. And after we stented his RCA and his left main LAD system with about 96 millimeters of stents, we basically had the patient on VA-ECMO from the get-go, did the procedure on VA-ECMO. After VA-ECMO, we're looking at whether or not we need an Impella. EF is 10%, aortic valve not opening. So this is on VA-ECMO at 4 liters per minute, EF 10% with an LVEDP of 40. And this is a new metric I want all the operators to start measuring, is an LVPaO2. So the LVPaO2 was 65 in this patient who had bilateral lung injury and also had cardiac impairment. And so what that tells me is I put an Impella in, we're going to start driving more of that LVPaO2 up towards the brain of 65. So to illustrate that point, unfortunately I don't know if this next video will play, but what you'll see here on the right side is with an Impella in, the mixing cloud, which used to sit here, now actually sits over here, okay? So if you have intact lung function, now you would be sourcing oxygenated blood from the LV, and that would be fine. But in the setting of cardiopulmonary failure, this is where you're now sourcing more deoxygenated blood up towards the brain. So keep that in mind when we're thinking about differential hypoxemia and cardiopulmonary injury. Now, one of the things that's really important is to start thinking about how we monitor these patients. So another thing that we've implemented in our institution is looking at bilateral near-infrared spectroscopy of cerebral hemispheres. So what this allows us to do is look at that mixing cloud sitting in the aortic arch and looking at whether or not there's oxygenated or deoxygenated blood going through the right brachiocephalic carotid artery. And if you see asymmetry of the brain that's greater than 8% with peripheral cannulation via ECMO, this leads to about an 83% risk of acute brain injury. So as you heard from Jason, 75% of his eCPR patients are having neurologic damage. And that's even whether they're in hospital or out of hospital arrest. So I think this is an important point that came out. This is a really terrific paper that came out of Johns Hopkins Critical Care looking at using bilateral cerebral NIRS. Now this is another really interesting paper. This drives the innovation of the field. This is actually a postdoc. I can't pronounce that name. But basically he's a wonderful guy. I called him up. He's actually in Australia. And I said, listen, I've been reading your papers. Turns out he's like 24 years old. And he's been writing these phenomenal papers. I would check him out. And what he's been doing is CFD modeling with VA-ECMOs and all sorts of cannulation strategies. And this paper really caught my eye. So with peripheral VA-ECMO, he's looking at a return at position 1, position 2, position 3, and position 4. And what he's looking at is the effect on the mixing cloud. And what he shows pretty effectively is that the only position where you'll actually get complete perfusion of the aortic arch is if you position your return cannula at position 4, which is just past the left subclavian artery. So that's a very difficult position to achieve if you're trying to do femoral cannulation. And so, but that's the only one that gets you back towards normal perfusion of the aortic arch. So if you look at the longest existing commercially available return cannula, this is it. It's the Medtronic Flex XL cannula. It's 55 centimeters in length. It only comes in 17 and 19 French sizes, primarily because of Puceau's law. So Puceau's law basically says that a fixed radius across the entire length, what happens is as the length increases and the radius is fixed, you're going to get more and more resistance across this cannula. So that means that your flow is going to drop as you start to get to the tip of the cannula. And actually, I spoke to the engineer who made this cannula, and they said they really couldn't go beyond 55 centimeters to create a 70 or 80 centimeter cannula because they would drop the flow so significantly you wouldn't be getting enough perfusion. But that's what we have clinically. So we started testing this out in our preclinical lab. So this will be presented at TCT, and and the paper will be coming out. But Peter Ostadal in the Czech Republic has been generating some really phenomenal models with ECMO. And this is a model of north-south syndrome in a swine. And basically, we replicated the model where you get above the diaphragm hypoxemia, and then below the diaphragm is hyperoxemic on VA-ECMO. And so what you're looking at is arterial PaO2 levels at the LV, aortic root, aortic arch, thoracic aorta, then the abdominal aorta on peripheral VA-ECMO. And what you see here is that on peripheral VA-ECMO, it's not until you get to the thoracic aorta that the PaO2 starts to come up in this north-south syndrome model. If you add an impella in the dark blue, you can see that actually you drive the PaO2 down in the thoracic aorta. Again, what you saw in that clinical case. The mixing cloud gets pushed down. But if you actually do this with a long cannula, and in the pigs, the 55 cm can get up to that position, you can actually normalize your PaO2 across the entire range. So you could actually potentially obliterate north-south syndrome using a longer cannula sitting in the thoracic aorta from a peripheral position. Now, what's interesting is one of the questions that came up is if we're returning 4 liters of flow closer to the aortic valve, do we actually increase load on the ventricle? Because we're now blowing closer to the aortic valve. And it turns out that the systolic pressures and the LV, mean aortic pressure, right radial pressure, actually all stay completely stable, whether using a long cannula or a short cannula. And in fact, the LVEDPs, to Jason's point earlier, actually come down, especially if you have a normal right atrial pressure. So that's where you can get some of that preload reduction with VA-ECMO. So we took it one step further. We're now in a first-in-human proof-of-concept study, taking patients with cardiogenic shock and basically implementing the Medtronic Flex XL 55 cm cannula, which you can see as the cannula reaches just below the diaphragm. On the CFD modeling, that's between position 2 and 3. So we may or may not be achieving what the CFD modeler showed, and that's what the intention of the study is. One of the endpoints of the study is to look at the hemodynamic effects of a long cannula, positioned closer to the aortic valve versus a short cannula. So patients come in, we put in the long cannula, we measure hemodynamics with a Langston catheter and a PA catheter, and then after 15, 20 minutes, we swap the 55 cm for an 18 centimeter cannula and repeat the measurements. And they leave the lab with an 18 centimeter cannula. And so in these patients, we're seeing LV systolic pressures are the same, whether you use a long or a short cannula, but the LVDPs are coming down again with that preload reduction. The mean aortic pressures are up because you're on ECMO now compared to pre-ECMO, but we're not seeing a significant increase in those aortic pressures compared to long versus short. And the PA pressures also remain quite stable. So we're not seeing a hemodynamic negative effect of using the longer cannula at that position 2 or 3. Now, what happens in north-south syndrome? So far we've enrolled 4 patients. The 4th patient had north-south syndrome. So what you're looking at is the right radial PaO2 as a measure of that right brachiocephalic artery perfusion. Pre-ECMO, PaO2 72, with the long cannula, 73, with the short cannula, 69. So we're not obliterating the north-south syndrome. So our Australian CFD modeler is potentially correct. Position 2 and 3 doesn't solve the problem. Got to get up here towards position 4, which is something we're developing now. So I think one thing to keep in mind is that there's expanding use of VA-ECMO in the cath lab. AHA now has a 2A recommendation for eCPR. eCPR is the most egregious form of cardiopulmonary failure. We know that LV unloading makes sense in those cases, which may lead to cardiac recovery, but we've got to get really focused on heart and brain recovery. So think about those cases when you start to look at how you're perfusing both the heart and the brain and optimizing outcomes for these patients. Thanks very much.
Awesome, this is great. So I have a question for you. Instead of using a long femoral, any thoughts about axillary artery approach to get to that 0.4?
Absolutely. So as you all know, as axillary operators, one of the challenges is putting a cannula into the axillary position. So the solution really is VA-ECMO, right, where you're putting another venous return back in. That gets us up to that 70 to 80 French, cannula configuration. The axillary cannula, is challenging in the sense that, typically we're putting in 15 French cannulas. For everyone who's done and looked at the ARMS registry that Jamie McCabe put together, looking at axillary CP, for example, we know that that's a very difficult thing to do. I think if Raj Tayal's here, I think we could probably feel comfortable if Raj is doing it. But that's a pretty challenging percutaneous approach. Surgically, I think that's certainly reasonable, is to convert to VA-ECMO. But I think if you're doing it all percutaneously, probably you're going to lean towards VA-ECMO. But the risk, of course, now is more bleeding, more incisions. Yeah.
Yeah, absolutely agree. It's just also the complication if you're doing percutaneous, putting a big cannula, the risk to the brachiocephalic injury is just a very high-risk area unless you have surgical. Really interesting data, Navin. So questions, a few questions actually. So if you put the cannula, the return cannula is so high, you're still doing retrograde flow. Is there any concerns about the oxygenation to now having South-Nor syndrome where you're below the, your kidneys are not well because you're still going retrograde and the forward flow from the LV, was the Impella CP. I don't know how much it's going to be able to counteract.
Yeah.
Second question, follow-up to that. I mean, thinking about it, could you use a multifenestrated, like you do the venous drainage, but do that on the arterial side and do a multifenestrated to overcome that problem?
Yeah.
And then the third, what we've done once is use a Protect Duo on the right side and then do the inflow venous, the outflow is arterial and why in the circuit. And that way, if your concern is putting too many cannulas in, which, always risks come with it, but that's one additional way that you can kind of.
Yeah. No, I agree with all of that. So I'll start with the third and go back. But so the dual lumen cannula creates more of an opportunity for now reperfusing through the PA circuit back into the LV and getting more of that oxygenated blood. Protect Duo, as you know, 29-31 French through the IJ in an emergent crash and burn scenario. Probably not something we want to do in STEMI shock with Cangrelor and everything else on board. So I haven't been doing it in my STEMI shock practice, mostly because of the bleed risk. And also, we're usually in the femoral environment at that point. To your question before that about multifenestration, so our CFD Zoom kid out in Australia did a really nice paper looking at multifenestration flow. And actually what you'll see is that most of the flow on the inflow or on the outflow actually comes from those proximal ports. So if you're going to do multifenestrated on the arterial side, most of the flow will come in the abdominal port, and it won't actually get up to the tip as much. And when you're draining, it's the same thing. Most of the drainage is from those proximal ports, not the SVC port. So that's one of the challenges. Forget your first point, and you probably forgot it too.
No, about the oxygenation. If you put the cannula, if you do an end-hole cannula and you put it all the way to the left subclavian, and you're.
Oh yeah, with the abdominal flow. Okay, I was trying my Jedi mind tricks on you again. So that's right. So this question of abdominal perfusion is really important. So what we're starting to see is that if you start to perfuse through that arch system, a lot of that blood actually comes down, and we've placed renal Doppler wires into the renal arteries, and actually all that flow has still got a good map and it's pulsatile. Now remember, we're doing it in those patients who have pretty good intact ventricular function or who have a CP or a 5.5 supporting. So that's where those do actually outcompete and you get a really nice flow. But it pushes the mixing cloud, it eliminates the mixing cloud is the key point of trying to do that. But the abdominal compartment we've been measuring, and right now renal flow seems to be pretty good. Yeah.
Okay, thank you. For the sake of time, we're going to move on to the next speaker. Dr. Hirst is going to be presenting stent thrombosis and AMI shock.
Tough presentation to follow. I think that everybody, probably myself included in the crowd, is probably thinking the interventional heart failure track. Are we trying to interventionalize heart failure or heart failurize intervention? But just wanted to say tip of the cap to everybody in terms of the organizers, and a heartfelt thank you to the organizers as well as to Navin for the kind invitation for the opportunity to speak here today. So the case that I'm going to present is an acute in-stent thrombosis, and it's complicated by cardiogenic shock. I don't have any relevant disclosures. We'll just jump right into the case. This is a 75-year-old female. She was evaluated in the community in one of our acute care access clinics, and she has typical angina. Her medical history includes hypertension, dyslipidemia, and she's a reformed tobacco user. Her family history is significant for clinically significant ASCVD. Her mother had a fatal MI at 57, brother had a fatal MI at 51, and her son has undergone coronary bypass grafting surgery at 52 years of age. She has a left bundle on her EKG. Her transthoracic echo shows a normal left ventricular systolic function, normal left ventricular cavity, and no significant valvulopathy. She was then referred for anatomic testing. She had a total coronary artery calcium score of 427 in Gaston units, with the majority of the distribution within the LAD. And here is her coronary angiography. And so you can make out the discrete lesion in the proximal LAD. And 2 slides here, panel A and then also panel B. Panel A, an operators looked at coronary intervention for the proximal LAD lesion after establishing distal wire position in the LAD, looking to pre-dilate the lesion with a 2.5 by 15 millimeter compliant balloon from distal to proximal in serial fashion, then did implantation of a 2.75 by 18 millimeter drug-eluting stent. And then that was further tried to, there was a small amount of shoulder and underexpanded LAD mid-portion stent that I think that everybody can appreciate in the northeast corner of the first panel. And then looking at panel B, I sort of call this no-go post-dilatation. Along the original wire, it was mentioned in the narrative report that the wire was pulled back and then re-advanced into the distal LAD. And over that same wire, additional equipment was passed into the distal LAD, looking to post-dilate that underexpanded portion. The operator at this point decided to use a buddy wire to try to, again, facilitate or massage additional equipment and still incapable of doing so. And so we have an underexpanded stent, and at this point, the patient did become unstable, complaining of chest discomfort, increasing escalation of vasoactivations in the cath lab, and we can see that there's an amount of thrombosis that is now occurring in the LAD stent, and then in the middle portion, it's extending into the left circumflex, and TIMI flow is now compromised within the LAD as well as the circumflex system. And so you can see that we're going now from a higher acuity to a highest acuity of the interprocedural chronicity. And the operators at this time decided to transition from radial access to femoral access. Both wires were inserted to gain distal wire access to the LAD as well as the circumflex. There was mechanical thrombectomy as well as plain old balloon angioplasty that was employed to reestablish coronary flow. The patient left the outside hospital cath lab with an intra-aortic balloon pump, and you can see that their wall motion is mildly impaired with persistent anterolateral regional wall motion abnormalities. And so I think that here, this is probably a good enough time to sort of recap a little bit about what we know so far. And we have a 75-year-old female that was referred for coronary angiography for typical angina and abnormal anatomic testing. But we don't really have a good idea about why this patient had all of a sudden acute unexplained in-stent thrombosis. And when we're looking at some of the procedural elements, there really wasn't a physiologic assessment, and maybe there wasn't need to be, just given the abnormality of the coupled symptoms as well as the defined coronary anatomy. But there was no intracoronary imaging pre-intervention, post-intervention, nor was there a critical evaluation of the angiograms looking to define the mechanism of thrombosis. So she shows up to our CCU. She's still complaining of ongoing chest discomfort, increasing levels of vasoactivations, and at this point, I want to direct you to the middle still frame of the angiogram, where you can begin to see that there is a small, faint, dark radiopacification that is within the stent that was previously deployed, and then additionally smaller filamentous areas that are extending all the way out into the aortocerebral junction. When you further blow that up, you can sort of see that this is a fractured guide wire that has unraveled, and the IVS images show us that not only in the not only in the transverse, but also in the longitudinal. And likely the way that we're going to put together the mechanism of thrombosis and also guide wire fracture is that the operator, after pulling it back into the left main coronary artery and reinserting it into LAD, ended up tracking into the subinterval, or abluminal space. And then further, this was probably corroborated by the narrative of inability to pass additional equipment, really being stuck there at the shoulder, unable to cross. And so the next question was, well, what would we now do? And if you're looking now at the left-hand frame, you still sort of that fractured, unraveled guide wire with a lot of this faint opacification with filamentous material that's extending all the way back into the aortocerebral junction. Again, the diagnostic angiography, when brought back to the lab, you can see that there's a considerable amount of thrombus that's hanging out in the proximal LAD at the level of the under-deployed stent, as well as the left circumflex system is now gone. So at this point, we decided the patient really needs to have better support. So the intra-aortic balloon pump was abandoned. Using that same access, we put up an Impella CP. Then we used a right heart catheterization to further phenotype the patient's hemodynamic status, followed by IVUS-guided true lumen confirmation space of wire placement in the LAD as well as in the left circumflex. And then the question is, well, what do we do about all of this material? there's a couple of different techniques that we'll get to in subsequent slides, but the real challenge is pairing the patient's clinical scenario with how best to treat all of this, because we're talking about now recurrent in-stent thrombosis and deteriorating clinical status and escalating cardiogenic shock status. And so we decided that probably the best way to reestablish coronary flow in a salvage maneuver would be pinning all of this filamentous material to the abdominal space by performing bifurcational stenting of the left main, LAD, and circumflex. And so here on the right panel, you're sort of seeing this IVUS-guided placement of the left circumflex stent and then an adjacent balloon that's hanging out into the proximal LAD left main interface. The next is you're going to see that the deployment of the left circumflex, and again, we were not dealing with any de novo lesion within the left circumflex. This was really essentially to reestablish flow and pin whatever filamentous material that has invaded that space to ensure that we don't get recurrent stent thrombosis. And then that's in the right panel, and then we also have deployment of left anterior descending artery stent, and that right panel that's followed then by post-dilatation in the balloon with the angiogram is hanging out all the way past the aorto-osteo junction, really to ensure that we've pinned all of that against any coronary space. And finally, we were able to reestablish coronary flow, but you can see that the rest of the coronary vasculature is spastic, it's vasoconstricted, and ongoing cardiogenic shock then really allowed us to further evaluate the patient's phenotype, and we had to escalate to VA-ECMO therapy and keeping the keeping the Impella CP as an LV vent. And so you can sort of see that patients had a pretty sort of prolonged and protracted hospital course that started with the index procedure and then post-operative day 54. But immediately after placing the patient on VA-ECMO, we did have a pretty good signal of LV recovery, looking at the pulsatility. The patient was eventually decannulated, de-escalated to an Impella 5.5, and this was at an outside hospital that was capable of caring for this patient over a longer period of time, but developed some respiratory issues, needed a tracheostomy, eventually weaned from vasoactive agents, and on post-operative day 4, after spending some time at an extended care facility, is discharged home. And so looking at the algorithmic approach to the guide wire fracture and loss in situ, there's a couple of different ways about sort of managing these patients. But if I direct you over to panel A and then the right column, we're already looking at a guide wire fracture in situ, and then also the guide wire has unraveled. So the ability for us to evaluate what the most appropriate strategy was really IVUS guided. And critical evaluation of the angiograms as well as the IVUS imaging of both limbs, the left main, LAD, and circumflex, showed us that it was really suitable for us to try to pin this, all of this filamentous material up against the stent, or between the stent and the native vasculature. Euro-PCR, on the other hand, gives us a couple of different strategies. The wire twirling effect, potentially aspiration catheter, guide wire, as well as trap guide, different techniques. But I think that pairing the patient's clinical course along with the best way to reestablish coronary flow is going to be most helpful in this case. So again, a patient-centered approach. So key learnings for the operator and for the team, I think that invasive angiography and coronary intervention is not benign. I think that really this case underscores the heterogeneity that we see in the community practice, and that the importance really for us is looking at a homogeneous approach to some of these patients. So if you've been on sort of a sports team before, many of whom in the crowd may have heard coaches say, failing to prepare is really preparing to fail. I think that the importance of coronary imaging pre, intra, and post not only underscores the evaluation of the morphology, but also ensures informed clinical decision-making for appropriate pre-dilatation and lesion preparation for successful stent deployment. If there is a discordance between your coronary angiography, like this in this case, as well as some type of clinical course, then that discordance must be explained. I think we don't leave the cath lab unless there's an explanation or some type of mechanism. And then, as I mentioned, really an individualized patient-centered approach to care is really paramount to trying to ensure hopeful recovery in sort of a catastrophic event such as this. So I just wanted to say thank you again for the opportunity to speak here today, and look for the panel for some engaging questions.
Hey, Colin, that was horrible. It's a great case, a really great illustrative case. But, really just every interventionalist nightmare, right? Once you start digging and then the snowball just continues to accumulate. I think the key maneuver here from my perspective, given all of the shortcomings of the initial planning stage, was, transferring the patient, getting them to a center which has the capability to escalate as needed. So what was the thought process, upon arrival? I mean, this patient was obviously unstable. Was cardiac surgery consulted? And, was there any discussion about just considering bypass before the patient deteriorated?
Good question. I think that the clinical course of the patient probably dictated how we decided to proceed. Clearly there was some type of discordance between what the angiograms were showing, and going back through those transferred angiograms, it was pretty clear to me that potentially something was missed. So taking the patient back to the lab, and I think that this may not be a situation which is unique to myself at my institution, but when you see a patient that is sort of slowly going downhill, the likelihood of cardiac surgery being more involved is inversely proportional to the rate of deterioration of the patient. And so at that point, when cardiac surgery had been informed about what's going on, it was really for, do you want my help with VA-ECMO support, or do you not want it with VA-ECMO support? I don't think that they really sort of were looking at taking the patient, but I think that that's a really good, it should be part of the clinical algorithm of decision-making for how to proceed with this patient, because there may not be a percutaneous option for the patient if there has been a clear defined pathway of recurrent thrombosis.
Yeah, no, I mean, congratulations on bailing the patient out. I mean, I think sometimes the idea of getting somebody on hemodynamic support, letting the dust settle, and then figure out what's next. But as you illustrated, the patient was not doing well. So congratulations on a great case.
Thank you. Yeah,
Thanks,
I think
Colin.
that also it just sort of highlights teamwork, right? I mean, I think that the more people that you get involved and the more people that you ask for help, at this point, probably ego and humility are probably ego. You have to sort of check that at the door and be humble to ask for help when in moments of critical need. So I think that sometimes it's good to be lucky than good.
Yeah,
So,
that was great. Thanks, Colin. That's a great case. Thank you.
thanks, guys. Thanks.
Next, we have Raj Patel, who's going to be discussing a case of VA-ECMO and AMI shock in the U.S. Raj is coming to us from Oaksner, New Orleans. Welcome, Raj.
All right, thank you, Dr. Kapur, and the course organizers for the opportunity to present here this afternoon. Maybe I'll go over here so everyone can crane their necks the other way for a while. All right. So this is a case of a 47-year-old gentleman who has a very strong family history of coronary artery disease. Everyone in his family gets coronary artery disease at or about 40, and they have lipoprotein lase in the 400s. So he has a known ischemic cardiomyopathy with an echo showing an EF of 20%, a left ventricular end diastolic diameter of around 7 centimeters. And he's got known CTOs of the LAD, the circumflex, and the right. He underwent bypass graft surgery in his mid-30s. And he had known Lima to LAD that was patent, but all the SVGs were down. And he was at our institution undergoing workup for heart transplantation. His VO2 max was around 9. And so as this procedure was, as his workup was ongoing, he developed, unfortunately, acute cholecystitis. So he got a PERC drain for that, and after going around for a month with the PERC drain, he was still having right upper quadrant pain. So the abdominal surgery team decided they had to bite the bullet, and for some reason they ordered a PET stress test on him, which of course showed nothing useful. But they had to go forward with the surgery, or he was going to go forward in life with a PERC drain for whatever time he had left. So we presented one morning, a Friday morning, for a lap chole. It was a rather unremarkable surgery. The anesthesia team was very judicious with the fluids. He got a total of 500 cc's of saline during the procedure, so they're watching out for that. Went to the PACU. New ST depression was noted on telemetry by the PACU nurses. General surgery was notified. Nothing was really done at that time. By the afternoon, he was tachycardic and hypotensive, and at 5:30, it was time for the general surgery resident to check out and called cardiology after noting that the patient's heart rate was 100, blood pressure was low, the patient was tachypnic, and he was fairly hypoxic, but still awake. The cardiology fellow immediately comes to see the patient, and in front of the patient, in front of the fellow, the patient arrests. She immediately defibrillates the patient, gets ROSC, blood pressure is 80/50 on a fairly decent dose of epinephrine as shown here. So of course, we looked at the patient's anesthesia record. He only got 500 cc's of volume. The ROSC EKG showed nonspecific ST changes, clearly no ST elevation, but there was concern that maybe the Lima graft had gone down or something had happened to the Lima. So the plan was to take the patient to the cath lab, place an Impella CP initially to stabilize the patient. After shooting the coronaries, place a swan to see what else might be going on with the patient, figure out how we could get this guy better resuscitated. So an Impella CP was placed through the femoral artery. That brought the map up to 90. Again, still on epi, 1 microkilogram per minute. And this is what the patient's left system looked like. The only difference between this and his prior angiogram is the first septal and the first diagonal are now gone. They weren't big vessels, but they're definitely gone, whereas they were there before. And then as you can see, his Lima graft is working fine, and he's got collaterals to the PDA there. Here's just another view of the Lima graft. All right, so what about the right heart cath data? So we had the swan in by this point, and his PAPI was 0.8, so his CVP was quite high, and his wedge was high also at 30. He was still satting 50%, and this is with the cardiac anesthesiologist now bagging the patient. So we make the decision to go ahead and intubate him. So we intubate him, he's on a FiO2 of 100%, PEEP of 12, and we can't get his oxygen saturation any higher. We start nitric oxide at 20 parts per million, the SAT comes up to 80%. Still not good enough, right? And so the question now is, with the PAPI being low, with a left-sided pump in on a high dose of epinephrine, do we place a right-sided pump in, or do we go to VA-ECMO? So we chose VA-ECMO due to the hypoxia. That's kind of the way our cardiogenic shock protocol is written. If he had biventricular failure without hypoxia, we would have put a right-sided pump in. If he's biventricular failure with hypoxia, our shock protocol, like many of yours, recommends going on to VA-ECMO. And so that's what we did. Limb perfusion is important to us. This is with the Impella, not on ECMO, so his output's better, but again, he's still on a high dose of epi. And there's our antegrade perfusion. And here's our final setup. So there's the swan, the orange arrow is the Impella. The blue arrow is the venous inflow into the ECMO circuit. The red arrow is the arterial return, and the green is the oxygen tubing for the particular VA ECMO system we were using at that time. Then, of course, part of our VA ECMO protocol, when doing peripheral VA ECMO, everyone gets a right radial or art line to try and avoid some of the issues that Dr. Kapur was talking about, although based on his data, obviously not a perfect solution. We turned down the Impella to P3 to avoid exactly that, the Harlequin syndrome or North-South syndrome, and our right radial saturations were good, as was the PaO2. Oops. Can I go back? I accidentally hit the button. Anyway, there we go. Thank you. We were able to come down on the epinephrine. His urine output increased immediately once going on to VA ECMO. His lactate normalized within 24 hours. And we started weaning the ECMO 48 hours after going on to VA ECMO. Our practice pattern has been to limit our ECMO runs to as short as time as possible for two reasons. One, for the inflammatory cascade that's released due to blood encountering a large artificial surface in the oxygenator. And two, because our resources are fairly limited at our hospital, and an adult patient is on VA ECMO, there has to be an ECMO tech bedside 24/7. So we can't do too many VA ECMO cases at a time. So after 48 hours, we were able to wean the patient off ECMO, and we took the patient to the cath lab. And then we had the right radial A-line access, so we used the radial to peripheral system to basically put up a balloon and get tamponade at both the arterial cannula side and the retrograde perfusion side, as shown on the picture on the left, or your right. Brought the patient back to the ICU, and then after 96 hours, after ECMO decannulation, we were able to wean the patient off the Impella CP and remove that in the cath lab. And he was eventually started on guideline-directed medical therapy and discharged hospital day number 12. So what's the data on VA ECMO and ECPella? If you do a PubMed search, you'll find probably as many papers showing neutrality with ECPella versus positives as a result. This is one of the European papers that propensity matched VA-ECMO patients with what in Europe they call ECMELA, in the US we call it ECPELA. And there was a 58% versus 65% mortality in the ECPELA versus, or ECMELA versus the non-IMPELA group in this particular study. But again, if you do a literature search on these retrospective studies, you'll find there's many showing no difference. Here's some perhaps more interesting data, a large meta-analysis of 17 studies of patients who underwent VA-ECMO with various venting strategies as shown on the screen here. And if you look at the bottom of this forest plot, you'll see, though, the venting strategies seem to do better than non-venting strategies when recovering patients with acute MI cardiogenic shock. So I know our time is limited, and I'm happy to take questions. But just to summarize, I think it's important to develop a cardiogenic shock protocol and a multidisciplinary cardiogenic shock team, as my colleagues have already alluded to. And one of the things that we haven't talked about yet is if you do have a shock protocol and you're tracking your data in these areas where data is relatively sparse, you can look back at your outcomes and see what's working, or at least start to develop hypotheses as to what works and what doesn't work. And this is certainly a relatively data-free zone. Treatment of cardiogenic shock, as my colleagues have already told you in great detail, involves more than supporting the mean arterial pressure, unloading the left ventricle, supporting the right ventricle, obviously providing oxygenation, as this case demonstrated, ensuring limb perfusion, and then obviously correcting the metabolic derangement to get the patient back on their own circulation. And then I think we should take note to make clinical decisions based on physiology. Every case shown thus far in this session has involved right heart cath data, and start learning what's been published and what's been working and what's not been working, and generate new hypotheses from there and testing those. So with that, I'll take any questions.
Terrific, Raj. Thank you. Questions from the audience? Questions from the panel? Comments?
One quick question about the ECPELA or ECMELA config. The timing of the venting, would that have an impact on your native recovery and the mixed cloud, which Navin you talked about, the venting timing?
Yeah, so that's a great question. So actually, Benedikt Schrage, who Raj pointed out as the German cohort with ECMELA, is running a clinical trial called Unload ECMO. So they're looking at the pre-ECMO versus post-ECMO use of Impella to see if there's a change in outcomes. Preclinically, we've tested this, and we've seen that there seems to be a better unloading effect if you start with Impella, then do ECMO, as opposed to ECMO, then add Impella. Whether that translates into a clinical outcome, we don't know, which is why the Unload ECMO trial is important. I think as you're seeing in a lot of these cases, and Raj, we'd love to hear your comments, you know, the idea of initiating CP first to try to get some degree of hemodynamic support, especially in a coronary case, you know, in an AMI case, I think that's, you know, really very reasonable. It also depends, again, as you saw from Colin's case and other cases, depends on the clinical scenario. How sick is the patient? Are they deteriorating that quickly? The out-of-hospital rest, it's going to be the opposite. It's going to be ECMO first, stabilize, what we call at our center, resuscitate and then escalate. In these cases where you have some time, I think the idea of Impella first and then using VA-ECMO as a bailout probably makes most sense because of the vascular complication rate, you know, being doubled with VA-ECMO versus Impella alone. But Raj, do you have any comments on timing? Do you feel like there's in your practice, you've seen a benefit of Impella before VA-ECMO or VA-ECMO before Impella? Does it seem to have any effect or not really?
Yeah, again, and so just to put the asterisk by what I'm about to say, this is all anecdotal, right? I don't have data.
This is just based on your clinical experience, which is immense.
And so to Dr. Kapur's point, there does seem to be something important about unloading in the acute MI situation. I work at an institution that does a large volume, takes care of a large number of patients with advanced heart failure who have dilated cardiomyopathies, non-ischemic cardiomyopathies, and that seems to be clearly a different phenotype. And for when those patients develop decompensated heart failure and devolve into shock, we have now gone to more of a ECMO first strategy compared to a Impella CP strategy.
I think I'll make a comment. This is a case of, planning with good judgment is probably better than bailing yourself out with excellent skills in the lab. This patient was being evaluated for transplant. MVO2 is 9. The surgical team should have, got you involved and maybe probably assessed the patient with hemodynamics, maybe PMCS support prior to the operation that they did.
Yeah, First of all, great talk. I'm curious, how many circuits can you run at your place at once? Do you know what the capacity is?
I do. It's, so I work at Ochsner Medical Center in New Orleans, and we share our adult ECMO techs with the neonatal ICU. So we can run 8 circuits total at any time, assuming there are no ECMO techs who are sick or on vacation or anything like that. And that
Right.
so if the NICU is running some, that decreases our number. And this is one of the reasons where our cardiogenic shock team has become important, because as well as the physicians on that call, whoever's on call for perfusion gets on that call, because that person will know what our availability for ECMO techs is.
And this is a bottleneck that I think every center that's cannulating and doing ECMO with some frequency hit during the first wave of COVID, right? I mean, you know, we discovered, I didn't know, I discovered that we can run a maximum of 14 if we're really pushing resources, nobody's out sick with COVID, and we cohort the patients, right? So the geography of our medical center is pretty large, as it is for yours, I'm sure. And if these patients aren't cohorted, now we're down to like 10 circuits. So, you know, I have a problem with the AHA recommendations, because a Class 2A recommendation is a pretty strong endorsement for something that is very resource constrained. So, when somebody's arresting in front of you and you have a sort of a smoking gun in terms of what you can fix, that's one thing. But we'll fill up all of our circuits if we do eCPR on everyone that comes in through our ER. Like young, found down, but now has ROSC, but not doing well. I don't know. I mean, there's no statement there other than it's problematic.
I think I want to bring up that point in terms of as one of the, thank you, Navin, for this platform for the interventional heart failure community. As one of the junior attendings that has that background, one of my goals was to develop an ECMO program and hopefully an eCPR program. I started in August, and they told me we want an eCPR program by the end of the year. And I'm thinking there is no way that's happening. And to this date, we still are not there yet, but we're very close, because you introduce another variable of cardiac arrest. But now you're introducing a new team member, which is the emergency room. And so it has required, I think, something that we can't forget is the logistical aspect. I tell people the technical aspect of cannulating, it's pretty straightforward, probably even simpler than doing a complex PCI. But getting all the team players involved, and I think one thing we've done is practice runs, simulations, to make sure that we have practice, because eCPR is not something that we do all the time. And so actually hopefully in the next couple of weeks, we should be able to go live with our eCPR program, but it has taken a lot of practice in getting everyone on the same page. We have diagrams in the ED where every person is accounted for, who stands where, who's doing what. So I think it's important for, we highlight the importance of having a team, but to play a team sport, you need to practice it. And so I think that's really important for the space of cardiogenic shock especially.
Yeah, how many operators here are using Impella first for out-of-hospital cardiac arrest? So patient has out-of-hospital cardiac arrest, they come in, they've been receiving a Lucas device, for example, EKG shows anterior STEMI, but they're still actively being resuscitated. Is that someone you would consider for an Impella CP? So if anyone would say yes, raise your hands. Okay, so there are some operators who would consider Impella CP with active arrest, anterior STEMI, come to the lab for eCPR, because that's the alternative to the 2A recommendation, is try to get them on some support. And then Spencer, can you just, in your eCPR program that you're building, do you have Lucas in your institution?
Yeah.
And is that integrated into the algorithm?
That's something, so you mentioned the arrest trial and what Paul's done. We basically have tried to emulate that kind of algorithm in terms of the inclusion criteria. There are some EMS teams out in the boroughs that have the Lucas device, and our hope is that anybody that is under the age of 70 that is a possible viable candidate, get them onto the Lucas device as quickly as possible. If they are not and they're rolling into the emergency room, We have the Lucas device in our ER, and so we tell them to throw the Lucas device on immediately. Within 5 minutes, we try to do an assessment of whether this patient would be a candidate, and if so, you have critical care, interventional, heart failure, CT surgery all come down to the bedside, and we decide whether we cannulate or not.
I mean, for any eCPR program, I think a Lucas or automated external compression device is pretty mandatory. As you saw from Jason's case this morning, 82 minutes on cardiac arrest with active CPR with a Lucas device. So we'll move on to our next talk here. Thanks, Raj, so much for a great presentation. And so I'll introduce Nima Aghili. Nima is local to the Denver area, has become the local interventional heart failure expert. And Nima is going to be talking to us about AMI shock without native heart recovery. Welcome, Nima.
Thank you. All right. I can move the, oh, there you go. So my disclosures, thank you again for having me. So I was assigned to this talk, AMI shock without native heart recovery, and I kind of paused and thought about it. And, you know, all I could kind of define this in my brain was cathing dead people. And, you know, Denver, for, you know, few of you, I guess, familiar with Denver, everyone does not have any medical history. 73, never seen a doctor, they never think they're gonna have a heart attack. So it's actually not, unfortunately, uncommon for us to see, oh, can you play that? I mean, obviously it's a CPR. Can you guys play that video? It didn't play. Anyhow, it's an act, so this can be a first presentation, unfortunately, to see a medical doctor for a lot of patients that unfortunately we see. So interesting, my case is actually pretty much similar to what Dr. Kapur was presenting. 46-year-old male, very healthy, really no past medical problem. He actually just had a flight back from Belgium that day, got back to Denver. So having chest pain, his wife drove him to the ER. At first he was very stable, his initial vital signs were okay. This is EKG, clear inferior posterior STEMI. Got a STEMI call, start driving in, and unfortunately these calls usually happen at, you know, at midnight. Driving in, I get a call that the guy is arresting, VF arrest. By the time I get to the ER, was 25, 30 minutes of CPR. Given he looked young, the CPR started in-house, we decided to take the patient up to the cath lab. I started the case by placing a CP. About my institution, ECMO is available, but I have to call the surgeons to get the ECMO. So obviously when I'm in, you know, when I was at Tufts, I could go down to the ER, cannulate the patient for ECMO. Not available in my hospital now, so Impella is all I got. So start the patient, we put the Impella in with active CPR. As soon as the Impella goes in, his VF is stopped. He's obviously on multiple pressors. He got loaded with volume in the ER. As you can see, his initial EDP was only 14. Case kind of straightforward, proximal RCA thrombotic occlusion. We did thrombectomy, put a stent there, that looked okay. He's still on a lot of obviously pressors and epi and inotropy, and although his VF is stopped, he's having a lot of obviously suction alarm too. This is the left side. His LAD also had significant mid kind of distal disease at the time. This is actually a few years back case. I decided to fix the LAD too, so I put a stent in the mid distal LAD with kind of okay result. So at this point, it's still very shocky on a lot of inotropy, and obviously we decided to go with the right heart cath. And these are the right heart cath numbers. RA pressure is 20. His PA is 25/15. That gives us a PAPI of 0.5. His wedge is 12. His PA sat is 37%, as I said, in a lot of inotropy. His cardiac output is 1.9 with cardiac index of 1 and cardiac power output of 0.27. So again, ECMO is not available, or at least not readily available. So we added the RP. I don't know if that plays or not. So, oops, that's the RP goes up. So now he has a bipella. And amazingly, he did actually very good. So he was transferred to the ICU. As expected, he was on a short-term inpatient dialysis. We explanted his CP on day 3. His RP came out on day 5. He was extubated. He was neuro intact on day 5, and he was discharged on day 12 with full neuro and kidney recovery. This is his echocardiogram on day 1. He has, again, this is on bipella, as you can see, very dyskinetic heart with the EF probably around like 10 to 15%. And this is 3 weeks post when he came to see me in the clinic. He fully recovered his EF. So a couple of points about these cases. First of all, out of hospital or in hospital arrest without heart recovery is really not in any clinical trial. So the data is even way more limited than everything else that we talked about. We always like to do a thoughtful pause. Interestingly enough, when I started, then I used to have a maybe few seconds pause, but now this pause is becoming longer and longer. Things to consider, obviously, is patient age. Our guy is favorable, 46. It looks very healthy, doesn't have any known past medical problem. Duration of the code, and I don't know, I would ask the panel if there is any guidelines of how much of coding is acceptable. Would you accept a patient if it was coding for an hour or 30 minutes? Is there any magic number that can help us? And I couldn't find anything. Obviously, time to initiate CPR, which was very good because the arrest happened in the ER. And again, the other important issue is that it's an out-of-hospital arrest versus in-house. And again, favorable for this guy was it's an in-house arrest. As I said, I've seen a lot of patients with cardiac arrest, out of hospital, in-hospital arrest, and obviously we all know biV shock is very common. I think it's even way more common when patient coming in with arrest. I've seen it in anterior STEMI, in inferior STEMI, in non-ischemic cardiomyopathy, and I think you all probably know the reasons for it. You know, you have LV failure, increasing your RV afterload. You all know that our right ventricle is very afterload sensitive, so increasing having an EDP of 40 as the afterload of your RV, failed the RV. The same process or ischemia can affect the both ventricle. LV dysfunction, the high EDP can decrease the wall tension, can increase and decrease the RV coronary perfusion. And also, as we know, the two ventricles, they share common myocardial filaments, so they can kind of both get affected together. And a lot of these patients with longer kind of arrest, they come in with the biV failure. And as you all know, once you have RV failure, this is a meta-analysis showing if you have RV failure, you have higher mortality, higher cardiogenic shock, and higher chance of fatal rhythms. So very sick group of people. I love to kind of turn back to the panel and ask for what do you guys do? I guess a lot of places do ECMO first. But as we talked, thoughtful pause is really needed before you take in these patients. As we said, biV shock is very common. Upfront MCF support is recommended. Chases, I guess, varies by what your institutional capabilities are. I do like the biV Impella. I did this case 7 years ago probably, and I probably would still do the same thing today. I like the biV support. You rest the heart, you reduce the need for inotropy, and it kind of lets you wean one side and kind of see if that side is recovering or not. We're still obviously lacking data on this. Thank you.
Great, thanks, Nima. I think this gives a good perspective, balanced perspective on VA-ECMO as upfront for cardiac arrest versus alternative approaches. Impella first, considering bipella. How many centers here have RP at their program? Okay, and how many centers are doing bipella with RP? Okay, Yeah, so I think it's an important one. You know, Bipella, when it first came out, was really, for us, it was difficult to swallow from the intensivist perspective. Because they weren't sure exactly how to manage Bipella, right? It's very volume dependent. You've got to really volume load the patients. You know, I think with VA-ECMO growing, there's been a little bit of a drop in the use of Bipella, primarily because of the concern about the hypoxemia, as you hear. But I'd be curious to hear from the panel. So if you have someone who is not hypoxemic, who's doing fine intubation, you do the CP just like Nima did, and you complete a PCI, but the RV is struggling afterwards. So are we obligated to ECMO in those cases, especially in practices where ECMO has got a huge barrier? What are the options there? I mean, are people doing Protect Duo, which still requires an external circuit, extracorporeal centrifugal circuit, so not exactly that far off from VA ECMO? What are the options that we're seeing? And I'm kind of curious from the community operators who are out there. So maybe Mike and others who want to comment. What are you doing if you see BiV? What's the capabilities of the resources available to you, Mike?
So we do have the RP, but I think, you know, personally, I think cannulation is actually easier than you know, like sort of working the tortuous way up the P and putting up the RP. So our practice is that we go for VA ECMO femoral approach. I've only done one RP this year and it's, you know, I'll tell you, ECMO cannulation is a lot easier than putting up an RP.
Yeah, it's an important point to make because the RP has also changed, right? So now the RP is now the Flex RP. Flex RP is primarily IJ deployment as opposed to our ephemeral deployment, which is the legacy RP. So that also, I think, is still yet really to penetrate into the private practice domain. We're using mostly RP in post-cardiotomy shock or, you know, post-LVAD shock. But Protect Duo on the table, Mike, is that something you guys have on the table, you and Allison?
Protect Duo.
Do not use Protect Duo. Okay. All right. Other comments in the field about Bipella? Colin?
So Navin,
And then Youseff. Youseff, then Colin.
Well, I don't have a large experience. We've done probably about 4 Bipella cases over the last 5 years that I've been. And I've found that patients that are smaller in size do better with Bipella. I feel like, I don't know if there's something you've noticed. I mean, it's just a very small number, but that's something anecdotal that I've noticed. You know, we had 2 patients that did okay, and then the other did not. One did okay just until decannulation, and then ultimately did not do well. So only out of the 4 Bipella, only 1 made it out of the hospital.
Yeah. For the body size, I mean, usually it's the LV side that's the limiting factor. So if it's a large patient, then usually the RP flows okay, but it's usually the CP that usually needs to get escalated to a 5.5. So now you're starting with CP, adding RP, and then escalating to 5.5, all Bipella, but now really adding the large capacity left, right?
So we have not tried that. It would be interesting. So we've only done CP, RP.
Yeah.
We have not had any cases that we've done RP 5.5, but that's definitely interesting. Because I feel like it doesn't give you enough flow as much as an ECMO. And one other thing that we look at is like the degree of metabolic problem and how many pressors they're on. You know, if they're on like 3 pressors, lactate above 10, I just feel like Bipella is not just going to be enough to reverse the hemometabolic component of the shock.
Yeah, Tufts algorithm is lactate above 5. We would probably favor VA ECMO if it's metabolic shock with lactate above 5. Colin and then Mohit.
This comment is really about the thoughtful pause, and this is for Nima and then also for the panelists. I think that the thoughtful pause, anecdotally, I think that raises equipoise between all of the stakeholders who may be involved in the patient's care prior to bringing them to the cath lab. And I think that there's a lot of medical inertia when somebody arrives in the emergency department to get them to the cath lab, which is thought of more of as a therapy and less of as a location in the hospital. But in our institution, we use the Miracle 2 score, looking at risk stratification of patients that have had out-of-hospital cardiac arrest, and for those who may not be familiar with it, looking at duration of code time, patients' age, potential neurologic status, and other metabolic features, whether or not they've received epinephrine, what their lactate is, you know, to sort of look at if they have a score of about 4 or more, that the inflection point of in-hospital mortality probably exceeds that of 50%, and then there's a discussion about proceeding or not proceeding. In that thoughtful pause, or again, for everybody, do you use a risk stratification or prognostication model? And if so, what are you guys using?
Yeah, I don't think there's actually a great model. I mean, I would actually refer to, especially for out-of-hospital cardiac, eCPR, is that AHA scientific statement. So in the scientific statement, they do have a discussion about all the risk model, the scores. The problem is some of the data is not always readily available, so it makes it difficult. I think the thoughtful pause is critical, and as Nima said, that pause gets longer and longer, as you start to get more and more experience. But if you look at that AHA algorithm in particular, there's the pause in the ER, and then there's the pause right before cannulation. So as the algorithm gets more distributed, more experience, I think the idea is that you can even put in placeholder sheaths, for that first evaluation, and then collect the data for the second evaluation before you actually cannulate. Because then you're going to make a decision. Is it a CP? Is it BIP? Is it, going to VA-ECMO? Or is it stopping and not doing anything? And I think for us as interventionalists, we're missing out on the metabolic and respiratory component of the calculation. And that's where that AHA algorithm brings in that PCO2, the PA2 PF ratios, and also looking at lactates, even if they're up to 18, is by the AHA statement. Mohit?
So I guess in today's day and era, when we have so many circuits and things available, I think these are good problems to have, I guess. One thing which I think it also, again, depends upon the comfortability of the operator. I think if you're in cath lab, you're getting a bi-V impella. If you are not in a cath lab which does bi-V impella, they might do VA-ECMO with impella. So again, I think it's end up becoming more of what your institution is more comfortable with. Now, one of the things which we do look at is the complication, which I think will become a bigger issue as we can do all these circuits and all these things, but the complication again becomes the big problem. Now, the reason I say that is because CP and RP both can be placed in the cath lab, but we know they both have complications. But putting a 5.5 with the Protect DO, do I take out the question of limb ischemia? Do I take out the question of hemolysis and bleeding, become a bigger circuit? Even if somebody's bleeding, I do not need to give heparin drip sometimes with these patients. I think those are the questions which will come out. And I think that will be something which we all will have to think about as we progress towards this direction.
Yeah, Mohit, that's great points. And that's a great dovetail to the next session, which is going to be on the advanced heart failure shock side, where we're seeing early 5.5 escalation. And we'll discuss some of those strategies, especially because it brings in the cardiac surgeons, which is really critical. So I'm going to thank everybody for a phenomenal session. The complexities of AMI shock still remain. A lot of work to do in the space, but amazing work being done by the speakers and by all the members here at the Operators Enclave. So we're going to do a 10-minute thoughtful pause, and then we'll come back for advanced heart failure shock to close out the shock sessions. Thanks, everybody.